Hi, I'm Max Jacobson. I'm a fourth year medical student, and today I'm going to talk about a interesting patient case and get into some information on scoliosis as well. So first, let's begin with the patient's history. This patient is a 53-year-old male who came to the chiropractic office with complaints of back and neck pain after having 3 previous motor vehicle accidents and a history of scoliosis that was diagnosed as a child. Late in his 15th year of life, the patient was seen by a new doctor who diagnosed him with scoliosis. Before this point, he had only had slight symptoms of back pain that only occurred with physical activity, which he considered to be normal, never thought much of. The diagnosis of scoliosis was then made after he had already grown significantly, so his treatment options were limited, as we'll discuss later. The patient underwent surgical treatment in which he received a Harrington rod, a treatment which we'll show you and talk more about later. Over the next year, the patient recovered fully from the procedure and was actually able to play high school basketball during his senior year of high school. He was then pain-free, doing well until his 30s when he noticed some discomfort, some stiffness, but nothing much in particular. In 2002, the patient's troubles began when he was involved in a motor vehicle accident. His car was struck head-on by another vehicle, causing a whiplash injury to his neck. This caused the patient to have neck pain, but with rehabilitation, he was able to fully return to his baseline over time. Then, skipping ahead to 2013, the patient experienced another motor vehicle accident where he was hit on the passenger side by a vehicle coming from opposing traffic. At this point, this accident left the patient with severe neck, mid-back, and lower back pain. He also noted numbness in the fourth and fifth digits of each hand and felt like his legs were locking up. This also caused him to have a left-sided headache. In 2015, the patient unfortunately experienced a third motor vehicle accident when his car was again struck on the front passenger side by another vehicle. This resulted in the patient having more severe neck pain, which he rated a 9 out of 10, mid-back pain radiating to the anterior chest, also rated a 9 out of 10, and lower back pain, also rated a 9 out of 10. In February of 2016, the patient was evaluated in the office. He felt that the pain was stabbing in quality on both sides of his neck. The pain was somewhat relieved with lateral flexion of the neck and with extension, but neck forward flexion worsened the pain, bringing the chin down to the chest, as well as lower back pain also being increased with that movement. The pain was also worse with head turning, and the patient noted hearing cracking sounds in his neck whenever he moved it. The patient feels that overall his back is very stiff and he doesn't have a lot of good range of motion in any particular direction. He also feels that his grip is weaker on the left side, as well as tingling down the left side of his arm into his fourth and fifth digit. This also occurs on the right but is more severe on the left. The patient also experienced a fall in September of 2015 when he noted that his leg gave out because it was weak. In the primary care office, the patient was treated with Lyrica for his pain, which he could not tolerate. He also did not like Loratab due to the addictive potential. So at the current time, he takes ibuprofen to manage these pain symptoms, as well as regular chiropractic appointments. He also notes that alcohol decreases the symptoms of pain, so that leads him to drink nearly every day. He also takes some sleep pills, which he's not sure of the name of, to help him sleep because the pain keeps him awake at night. So we already discussed the patient's drinking. He drinks a half pint of whiskey and a couple of beers almost daily. He is not a smoker. He has no significant family history, and his past medical history is significant for hypertension that's treated with amlodipine, and a thyroid lobectomy for suspected malignancy that ended up having benign pathology, as well as the history of scoliosis. So now, let's spend a few moments discussing some basic information about scoliosis. Scoliosis, by definition, is a disorder of the spinal column that arises normally during adolescence. In scoliosis, there's lateral curvature of the spinal column as well as rotation of the vertebrae. So you need both to have true scoliosis. Curvature of the spinal column as well as rotation of the vertebrae. Scoliosis occurs in 1 to 3 out of 100 individuals. It's frequent in boys and girls equally, but girls are more susceptible to severe disease, including worsening of their curvature, and they're more likely to require treatment and surgery. There's some family history that can be significant for scoliosis. If a child has a sibling with scoliosis, he or she is 7 times more likely to develop the condition themselves. Also, if a parent had a history of scoliosis, their children are 3 times more likely to develop the condition as well. Most commonly, signs and symptoms of scoliosis begin with the prepubescent growth spurt, and this usually occurs between the ages of 9 and 15 years old. However, this is not always the case. So getting into the classification of scoliosis, there are 2 main types, structural and non-structural. Structural scoliosis is classic scoliosis, where you have a lateral curvature of the spinal column and rotation of the vertebrae without another underlying cause. And this can be subdivided into a few types based on the age. There's infantile idiopathic scoliosis begins between the ages of 0 and 3, and that's very uncommon, 0.5% of cases. There's juvenile idiopathic scoliosis, which occurs between the ages of 4 and 10. This is only 10.5% of cases. And then adolescent idiopathic scoliosis occurs in children 10 and up, and that's the most common form, which is about 89% of cases of scoliosis. There are also other uncommon causes of structural scoliosis, such as genetic conditions like Marfan's disease, Ehlers-Danlos syndrome, neurofibromatosis, and skeletal dysplasias. Other causes of structural scoliosis include more rare conditions such as tethered cord, syringomyelia, polio, cerebral palsy, muscular dystrophies, spinal muscular atrophy, and tumors such as osteoblastoma, meningioma, osteoid osteoma, etc. There is also non-structural or functional scoliosis, which occurs when the spine is normal in structure, but it appears curved on imaging or exam due to a temporary and changing condition. For example, if a child has a leg length discrepancy or a muscle spasm, this could cause the spine to appear curved, even though the spine is structurally normal. This also can occur with inflammatory conditions, such as appendicitis. Patients with scoliosis usually do not present with pain, but 25% of patients with the condition can present this way. Physical exam signs that you're looking for include posterior chest wall prominence, uneven shoulder height, increased prominence of one shoulder blade when compared to the other. You may also see a patient with uneven waist or hips, or with a difference in breast size. Now, our patient was examined well after his diagnosis of scoliosis and way after his treatment, so his physical exam was a little bit different. And his physical exam, it was noted that he had poor movement of his cervical spine and lumbar spine in all directions. He had normal reflexes bilaterally, but he had decreased sensation to light touch in the lateral aspect of his left forearm and hand when compared to the right. His strength was also somewhat limited. He had 4 of 5 strength in right wrist extension and 3 out of 5 strength in left wrist extension. His pinch grip was also weaker on the left than it was on the right. Straight leg raise testing on the left led to immediate pain in his back and posterior leg at only 10 degrees of flexion. Straight leg raise on the right, however, led to some back and posterior leg pain at 45 degrees. Costoclavicular maneuver caused the patient to have increased bilateral tingling in his 4th and 5th digits of the hand, as well as decreased radial pulse bilaterally. On cervical compression testing, the patient had pain radiating to the left shoulder and upper dorsal region, and also felt pain straight down the back. So now let's get into imaging. When a patient presents with possible scoliosis, the best imaging test to order initially is a standing PA film, such as the one you see here. In a patient with scoliosis, this will show greater than 10 degrees of spinal angulation. In addition, as I mentioned before, there must also be vertebral rotation, with most rotation occurring at the apices of the spinal curve. If there's no rotation, you must consider another cause, such as a bony tumor, intraspinal pathology, nerve root irritation, etc. Here in this image, we can quite clearly see the patient's Harrington rod, which he was treated with surgically to treat his scoliosis. We can also see that his spine is still quite curved. As you follow my mouse here, you can see the spinal curvature that still exists despite the treatment. Here's an AP image, again of our patient, in which you can see his spinal curvature and his Harrington rod. To measure the spinal curvature, radiologists measure the Cobb angle. To determine this measurement, the radiologist picks the upper and lower vertebrae that make up the ends of the spinal curvature, which you can see we did here. So we drew one line parallel to the top, we drew one line parallel to the bottom. Where those lines intersect is an angle right here. So what we did was we measured that angle, and that is our Cobb angle, which we use to quantify the degree of scoliosis. Here that angle was 35 degrees. So with our patient's history of scoliosis and 3 motor vehicle accidents, he has some pretty interesting imaging findings. So let's get into those. Here we have a cervical MRI. On the left, we have the sagittal view, and on the right, we have the corresponding axial view to this red line here going across the C3, C4 level. So let's start with here at the C3, C4 level. We can see that the cord, which is here, is not particularly compressed, and we can see that there may be a slight disc bulge here. And so now looking over at the axial view, we can see here that this is actually a fairly normal level for this patient. The cervical cord, which you see here, is not compressed. This looks fairly normal, this spinal cord level. We can see the nerve roots coming out here on the sides. So now let's take a look at the C4, C5 level. Here we can see on the sagittal view that the disc appears to be bulging out and actually impinging on the spinal cord. So now let's take a look at the axial view. Here we can see that the shape of the spinal cord here is pretty different than what we saw before. This was fairly flat before, and now it is compressed by this disc protrusion that we see here. So the spinal cord is actually being compressed here at the C4, C5 level. In addition, there's less space for the nerve roots to come out through the intervertebral foramina, which is causing the patient to have symptoms. Here's the C5, C6 level, where we can also see on the sagittal view there's a disc bulge coming out and affecting the spinal cord. So in addition, at this level, we have the intervertebral disc protruding out and actually impinging on the spinal cord, as well as limitation of the intervertebral foramina, so the nerve roots are unable to escape. And that's causing the patient to have pain. Here we have the C6, C7 level, where we can also see on the sagittal view, there's a disc bulge, and we can see that there's a slight disc bulge here, but not as severe as the previous levels. All right, now we're looking at a lumbar spine CT. We have the sagittal view here, and we have axials corresponding over here, just like we did before. So in this case, we're looking at the L2, L3 level. And here at this level, the main thing we need to see is that there's a slight disc bulge And also, on the axials, we can see that the intervertebral foramina for the nerve roots to escape is very narrowed here, as well as over here. Moving on to the L3, L4 level, again, we can note a disc bulge, which we can also see over here. And there's some bony spurring here that's narrowing the intervertebral foramina. But we can see that this looks at least more patent than the previous image. Over here, the intervertebral foramina is pretty narrowed. So the nerve roots are not going to be able to escape normally. Moving on to the L4, L5 level, we have some narrowing, worse on the right, and we have a mild disc bulge here. You can see the disc bulge pretty well over here. And here we have the L5 S1 level. At the L5 S1 level, we can see a disc bulge here. And we can also make that out pretty clearly on the axial here. When scoliosis is diagnosed, the most important thing to consider at first is how much growth the child has remaining. If the patient has a lot of growth left to do, there's an increased risk of the curve worsening. If the curve is mild at this point, observation and regular follow-ups are appropriate. And we can follow up and see how the child is doing, see if the curve is getting worse, until the child is skeletally mature. If the child is skeletally mature, or if the curve is severe, then treatment is required. Bracing, using a back brace, is used for skeletally immature patients that have progressing curves. The brace is custom fitted to each patient. It does not improve or correct the curve, but it simply prevents the curve from progressing. It's extremely important that the child is compliant with this curve for the specified number of hours a day to make it work. Surgical treatments are also good for some patients, especially patients with severe curves and skeletally mature patients. Our patient had a Harrington rod placement, which is a treatment that fell out of favor in the late 1990s in favor of newer surgical instrumentation. Newer approaches have led to a more physiologic range of motion of the spine, as opposed to the rod, like our patient has, that really limited his spinal mobility. Follow-up studies on patients with Harrington rods down the road in adulthood have shown that these patients have significantly more degenerative disc diseases and changes than control patients. They also have more frequent lumbar pain, even though many of the patients rated their pain only as mild. About 25% of patients with a Harrington rod as adults admit having daily pain. So based on this research, the patient's Harrington rod probably made him vulnerable to degenerative disc changes and lower back pain at baseline. At this point, the patient was then involved in 3 motor vehicle accidents that further damaged his spinal column. Now, these accidents cause trauma to the spinal column, and our patient is less able to tolerate that type of trauma because of his limited mobility. He has a large rod in his back that greatly stiffens things. So when he's in an accident, that impact is going to be transmitted more to his vertebrae directly above and below where the Harrington rod is placed. And we can see that with the spinal injuries that we've seen on these images in the cervical level and the lumbar level above and below his Harrington rod. When the patient is hit by a car, these levels directly above and below the rod are going to move more than normally because they can't rely on the movement of their neighboring vertebrae, which are braced by the rod. So it is important to note that a patient with a history of this procedure or other spinal fusion procedure is less likely to tolerate trauma than a patient without a history of spinal surgery or manipulation. It is also important to note that this patient appears to be using alcohol as a pain-reducing medication. This is an extremely important finding to make, as this patient should find a way to have his pain tolerated better without the use of alcohol in order to limit his pain. So we referred this patient back to his primary care office from the chiropractic clinic to discuss his alcohol use. That is all for this case on scoliosis and disc pathology. I hope you enjoyed it. Thanks for watching.